Good morning. Thank you for attending today's webinar on oral health in residential aged care. My name is Taylor. I'm a Network Officer for the Commonwealth Department of Health and Aged Care's local network. We are joined today by Dr. Carol Tran, co-founder of Oral Health Home, Gemma Collins, co-founder of Residential Solutions, and Bill Sewin, CEO of Dental Hygienists Association Australia, to have an important conversation around the importance of oral health care for residents in residential aged care homes and to educate us on the various service models and resources available. I'll begin by acknowledging the traditional custodians of the land in which we are virtually meeting today. I'm based in Brisbane on the lands of the Turrbal and Yagara people. I acknowledge and pay my respects to their continuing culture and to the contribution they make to the life of this city and region. I also extend that acknowledgement and respect to other families with connection to this region and any Aboriginal or Torres Strait Islander people who are here with us today. As network officers for the Queensland branch of the department's local network, we are committed to strengthening regional stewardship across the state of Queensland, including regional, rural and remote regions. This webinar is part of our ongoing effort to use local insights gathered through engagements and stakeholder relationships to deliver targeted education, improve awareness and access to services to better achieve outcomes for senior Australians. We will have a Q&A session at the end of the webinar. Please submit questions in the Q&A function. You may need to click on the Q&A icon at the top of your screen to activate the function before submitting any questions. We will attempt to respond to as many questions as possible. If there are questions we don't have time today to respond to online that are directly relevant to the webinar, we will share responses via email. This session is being recorded. You should receive a link to the recording via the email registered at the conclusion of this webinar. So I will now introduce you to our first guest speaker. So Dr. Tran is an oral health therapist with extensive experience in the care sector and private and public dental services. With a PhD in dentistry, Dr. Tran has been an educator at the University of Queensland and Central Queensland University, where she's developed and delivered evidence-based curricula. Until last week, Dr. Tran was a consultant oral health therapist for Queensland Health, Office of the Chief Dental Officer, where she advised on workforce strategy and policy. As a co-founder of Oral Health Home, she has developed evidence-based programs supporting oral health for older adults in aged care settings. So I will throw to Dr. Tran.
Thank you, Taylor, and welcome everyone for attending this morning. It warms our heart to see that there's been such a high level of interest as well, because quite often the discussions we have with staff in residential aged care is that while yes, it's important and we try our best in terms of incorporating care practices, it can be difficult in terms of the list of priorities that we do with everyday personal hygiene and care as well. So I'll ask for the next slide. So today I'm going to be presenting particularly on the evidence and the latest evidence for oral health and how it's linked to general health. Gemma will be presenting on the various dental practitioners that are across our sector, particularly in dentistry and oral health. And Bill will finish up with oral health service provisions, as well as Gemma, who will talk about that from a very lived experience, being a service provider in Adelaide. And also Bill will also talk about our oral health services model later on and what we can offer, particularly with the Dental Hygienists Association and our aged care chapter for our residents. So I'm based in Brisbane, also known as Turrbal and Yagara people country. So I'd like to also acknowledge the traditional owners of the land that I am present here at the moment. So I'm going to go next slide, please. Please forgive me if I speak too fast. So why oral health is crucial in aged care. I'm sure that everyone here is aware of oral health and its implications about why we need oral hygiene and keeping the bacteria off our teeth. But I'm also interested in hearing from others at the end of this presentation on the real difficulties and particularly the opportunities and challenges that we can potentially work together on how we can integrate oral health or what you're currently doing in your residential aged care facilities in oral health care and how we can help out. But just as a high-level overview, that yes, oral health is quite often overlooked in aged care, and quite often when we do see patients in residential aged care settings, we can see that before, when they were quite functional, they were looking after themselves quite well. but as they do age, sometimes the mobility and fragility of the resident does become increased as well. And that can be quite a challenge, particularly also when there's behavioural concerns at the same time. So for those who aren't aware, oral health is related to someone's quality of life. It has huge impacts on nutrition. And I'm going to present something today that you might have not heard of or thought about in terms of how oral health is linked to general health, other than its impact on diabetes, aspirational pneumonia, cardiovascular disease, and particularly cognitive decline. And we know that people in residential aged care are usually polymedicated, can be high risk of fragility, and also quite often dependent on caregivers as well. So I'm going to discuss that in quite a bit of detail, and feel free to ask any questions in the Q&A section as we move along this presentation. Next slide, please. So I'm going to introduce a new term called oral hypofunction. I'm curious to know if people have heard about this term. If you have heard about this term, please insert yes or no into the Q&A section. But what is oral hypofunction? The definition currently in the literature really describes it as poor decline in oral function due to age, disease, or neglect. So quite often what that means practically is that when us as dental practitioners look in someone's mouth, we'll actually count how many teeth are actually matching together in terms of how well they are chewing. So oral hypofunction really means how well can someone chew? Is their chewing ability good or poor? And that has huge impacts in terms of how their general health is actually going to be impacted over the coming years of their life. So what we look for in oral health is that how many pairs of matching teeth do they have? So 20 pairs of teeth, natural teeth, means that 10 on the top and 10 on the bottom. If you have less than that, then you are at high risk for oral hypofunction due to a lack of matching teeth used for mastication in particular. And the World Health Organization suggests that it is 20 is the number. So it's basically premolar to premolar, used for chewing function, to really create that bolus of food so it's easier to swallow. How you can measure this currently in your aged care facility, and you know your residents the best, is that do they avoid highly textured food? So we're talking nuts, well-cooked steak, rough foods such as biscuits, or should I say tough textured biscuits, crunchy foods such as fruit, apples, particularly well-cooked steak. Are they avoiding the well-cooked meats because they can't chew? We have tools as well, potentially we can use in the future, about measuring bite force as well as chewing ability. Quite often these residents, because of polymedication, do have reduced saliva flow, so they will sometimes complain about dry mouth, and it has huge impacts in oral health. Quite often you also see impaired lip and tongue movements that your speech pathologist will quite often report on, as well as dysphagia as well, and the inability or slowed ability to swallow. So because of all those factors, it actually increases the risk of choking. And when they actually change the texture of their diet, as quite often it's quite common, the risk of poor nutrition and oral infections developing in the mouth actually becomes increased because of lack of oral function, so a lack of chewing as a result of that. So the impacts on residents is that it's going to be difficult to eat, enjoy our food, and increases the patient's fragility risk, weight loss, as well as cognitive decline. Next slide, please. So I really wanted to introduce this term about, like, yes, we know that keeping our teeth is important, but we know the, I sometimes call it vague effects in terms of what it's linked to in terms of diabetes, hypertension, cardiovascular diseases, as well as dementia. But the real reason why we want to keep our teeth and dentures, residents having dentures in their mouth, is because that the poor mastication and its risks is that our residents are actually going to end up eating fewer vegetables and proteins, rely on soft and low nutrient foods, and experience malnutrition, weight loss, muscle loss, as well as accelerating cognitive decline. So research shows that poor chewing ability and less than 10 matching opposing teeth, so 20 teeth in the mouth altogether, is at risk for high dementia, it accelerates cognitive decline as well as increasing the risk of fragility. The reason why that is because of the lack of blood flow that's actually happening in the brain when we're actually chewing. So by the time the next time you put an apple in your mouth and as you're masticating, ask yourself, are you avoiding that apple because you can't bite into it whole, or do you actually need to chop it up into little parts? The fact that if we can't chew, it affects the blood flow to our brain. And because of the lack of blood flow and as well as decreasing and changes in our lifestyle and avoiding those highly textured food, we actually decrease the blood flow to our brain and actually accelerates cognitive decline and increase the risk of dementia. It's also linked to diabetes as well as diabetic control. So in one study, they showed their blood glucose levels and how well they could control. For someone that had poor mastication function, the HbA1c was about 9, and the HbA1c for someone with good mastication or chewing function was about 7. So this has real life world impacts in terms of why we want to keep teeth and patients wearing dentures over time, not because it's a cosmetic reason, but it's also because of a real chewing functioning reason and keeping these muscles going as well as the blood flow going to our brains as well. Next slide, please. So I'm going to acknowledge that I'm not a speech pathologist, I'm an oral health therapist, but the problems that we see sometimes with modified textured diets is that the ability to enjoy foods as well as the anxiety sometimes around foods with modified textured diets is that there is an increased risk of nutrition deficiency, potentially poor appetite because they're not chewing and masticating and really enjoying the textures as well as the flavor release in our foods. And because of that, potentially can lead to weight loss. Again, I'm not a speech pathologist. You're welcome to challenge me on this component and write your comments in the Q&A. Very happy to have this discussion ongoing and to see how we can really work together around these topics as well. So what happens is that with the lack of mastication, as well as potentially the inability to clean our teeth, that perfect storm actually increases the risk of bacteria in our mouth being stagnant. Because of the bacteria being stagnant, the residents have the risk of actually inhaling that bacteria in our mouth directly into our lung tissue. And when that actually inserts into the lung tissue in combination with dry mouth, and an impaired immune response or a lower immune response, is that we increase the risk of aspiration pneumonia, particularly if oral hygiene is important. So we really want to keep these teeth in the mouth because it actually is going to improve the oral health overall because the residents will be able to chew and swallow and hopefully reduce the risk of modified textured diets as well. Next slide, please. So why dentures are important and keeping dentures clean as well as well-fitting in someone that is aging. Again, it's not particularly cosmetic. While yes, it's an added bonus and yes, it is related to quality of life, is that dentures are incredibly important for proper nutrition, speech, social confidence, and also preventing facial collapse. Because they've actually got something that is actually opposing, you're actually working the muscles around the body's ability to chew as well as the face to again keep those muscles going. There was one study that showed that not wearing dentures actually again accelerates cognitive decline. So we want to actually make sure that these dentures are well-fitting, clean, to prevent the food avoidance, sores, and infection. So having someone dental or oral health related in your residential care facilities is actually incredibly, I'd say, important, being biased myself, to actually keep the mouth disease free and actually having well-maintained dentures to support better health outcomes. So I'm hoping that's actually going to give a different twist to people that's listening here. Well, yes, we know oral health is incredibly important. This is the real reason in terms of why we want to keep teeth in the mouth and keep them clean, as well as asking residents to wear dentures. And if there are ill-fitting dentures, to actually get someone to address this. Next slide, please. So I'm going to have a brief overview in terms of the oral health impacts on general health. Again, as I touched on before, aspiration pneumonia is linked to poor oral health. So the bacterial load in your mouth, particularly for someone who has an active infection or active gum disease, the amount of gum disease and the amount of inflammation that can be measured in terms of the plaque can be the equivalent of the size of your hand in terms of the inflammation burden. So because of that bacteria is actually sitting stagnant in your mouth, that bacteria is actually can be easily inhaled and end up in the patient's alveolus and into their lung tissue itself. So again, keeping these teeth are incredibly important, and we as oral health practitioners are here to support this, as well as potentially helping residents in aged care to keep their mouth healthy, as well as keeping their teeth and dentures healthy as well. This bacteria that I was describing in the mouth is also linked to heart disease and stroke. So there's been a number of studies where the bacteria in the mouth, because there's so much inflammation and blood vessels actually are actually inflamed and actually are basically dilated, they become leaky. So the bacteria in your mouth can actually directly insert itself or invade into the blood vessels, hijack its way all the way into the capillaries and arteries and end up in your heart tissue, in your heart veins and in your heart arteries as well. And these bacteria are so clever that they don't even need oxygen and actually live off blood products. So again, these bacteria have been cultured and actually been found actually in our heart tissue, in our arteries and in our veins as well. So we'd like to keep these teeth clean. It also worsens diabetes complications. So again, when I was talking about the chewing ability, for someone who actually has a good chewing ability is actually linked to their diabetes. In one study, they were showing that in a diabetic neuropathy clinic in Japan, the 90% of patients actually had poor masticatory or chewing ability. So it actually makes their diabetes worse, as well as the bacteria in our mouth can actually cause inflammation and make diabetes completely worse in terms of the diabetic control because of the inflammation that's actually present there. And the whole goes through a whole cycle. That's a lecture itself completely together. And again, I've touched on cognitive decline and dementia, that poor oral hygiene, that bacteria can actually end up in the brain as well, and is strongly linked to dementia in terms of outcome. Not only the chewing impact, but also the bacteria having the ability to actually create a gateway and a highway to your brain. You might see this in your residents as well, that because they are having pain, the ability to express that they are in pain or their changes in behavior because of something happening in their mouth can also cause discomfort and agitation and refusal to eat. So us as oral health practitioners have the ability potentially to work with your aged care facility to help prevent that from happening. Because another interesting fact is that 90% of all oral diseases are completely preventable with good hygiene and also potentially having the ability to chew as well. Next slide, please. So the cost of ignoring oral health, I'm hoping that everyone here that attends this will be like, okay, let's make this the top of our priority now, along with all the other priorities that's happening in aged care, is that it does increase the residents' risk of hospitalisation, particularly with aspiration pneumonia and malnutrition and the patient's fragility risk as well. In one study, they looked at a patient's mastication ability, so how well they can bite, and actually linked that with a wrist, the wrist, I should say, the holding task where you can actually measure the patient's grip strength. So the patient's ability to chew is actually linked with grip strength as well. And I'm sure everyone here knows that grip strength is actually a window in terms of what the patient's risk is for having a fall, as well as osteoporosis as well. It also increases care burden risks. So difficulties in eating might lead to behavioural issues and also lifestyle changes in terms of avoiding food in general, as well as increasing risks of overall body infection because there's something going on in their mouth. Overall, in terms of what happens is that there is a financial impact, that there are increase of medical costs and preventable hospitalisation. And in your care facility, particularly for patients in a dementia ward, that the ability for someone to actually go to a dental surgery is actually increased in terms of risks and also financial impact, because we actually need to move them through some form of ambulatory function to actually get them to a dental clinic. So if we can actually prevent that happening in the first place by improving oral hygiene or actually monitoring oral health overall, we can potentially prevent all this from happening altogether. Next slide, please. Can I just go to the next slide, if that's okay? Yes, okay, thank you. So back one, please. Just go back one more. Yes, perfect, awesome, thank you. So I'd like to finish off by saying that oral health is a priority and not an afterthought. In terms of what programs you can offer, so I am half the owner of our company called the Oral Health Home. I'm also currently the Vice President of the Dental Hygienists Association, as well as the Chair for Advocacy and Policy. And I'm particularly interested in developing oral health programs in a very different setting and in much more of a group setting. So think of a music therapist, but having an oral health therapist to educate your residents as a group, which particularly we think might be in a much more interesting scope compared to doing one-on-one care sometimes in the future. What can your facility do today? So you can review your oral care protocols. You can contact your oral health practitioner to say, hey, do I have a practitioner visiting my facility? Ensure that we've got up-to-date denture and teeth maintenance on the caregiver's schedule, as well as scheduling regular oral health practitioners to complete oral health assessments, because in Lee Care, there is an oral care function and there is an oral health assessment tool that us as oral health practitioners can record into that, as well as provide advice around that as well. So another quick spill is that we have recently received a grant from the Logan City Council, as you can see from the photos there, to actually create a seniors oral health program, particularly for residents that we want to target in the future, to talk about oral care, talk about chewing and cognition, and how we can help to keep our teeth healthy long term. So I'm going to hand over back to Taylor, who's going to hand over to Gemma to talk about the next slides. Thank you.
Thank you so much, Carol. The link between poor mastication and cognitive decline is a little bit terrifying, but very interesting. So thank you for sharing and providing us with some solutions. I have the privilege of introducing Gemma, our next speaker. Gemma is the co-founder of Residential Solutions, which they are a provider of mobile oral health for aged care. Gemma is a passionate advocate for preventative dentistry in the aging community, with Residential Solutions being founded out of passion to help change the lives of our older community within their aged care facilities. So thank you, Gemma.
Thanks, Taylor, and thanks, Carol, again, always a very insightful presentation. So if we can just get the rest of that slide up. Beautiful. So I'm going to run through a few different things. So first of all, I'm going to talk about AHPRA and the registered dental practitioners that exist underneath that. So there are quite a few different practitioners in dentistry, all with different levels of scope. We have general dentists, we have dental specialists, we have dental hygienists, we have dental therapists and oral health therapists. Plus there's the guys that do all the denture stuff, dental prosthesis. Everybody has a similar scope, but varies, all with the same goal, to provide oral health care to the ageing community. Next slide, please. Beautiful. So residential aged care facilities, their oral health service provision. So these are the different things that we contribute to in an aged care facility. So we take part in the oral health assessment, the oral health care plan, the oral health treatment plan. We provide minimal intervention dental treatments. From that, we can organise referrals to whether or not it's a dentist that needs to come on site or a different dental practitioner altogether. Medical, GPs or specialists if there's something else that's needed. We can organise some diagnostics, so whether or not that's just general dentistry or we need to look into some other things that we talk about, speech pathology and nutritionists with the allied health. We also can offer staff continued education, so we can provide face-to-face education, we can do online things, and of course there's lots of different publications. Sometimes we can create newsletters for you, or pamphlets that can go out to patients, or pamphlets that can go in the staff room, just some little helpful tips and things like that. There's also the clinical governance that we can provide, advisory committees, audits and your CQIs. Next slide, thank you. So oral health providers in residential aged care facilities. So one of the things that you'll find we do, so the most important thing is that we liaise with the care staff and the management on arrival. So if there's any concerns that you have that we don't know about yet, or something that's popped up that you will need us to know, we'll have a debrief with you before we go in. And we usually will make sure that we've got relevant medical histories before we see a resident, just to make sure that there's any behavioural managements or particular requests by a resident, that we're looking after everybody. We like to make sure that everybody knows that we're there on the day. And if there's anything else, you can come to us directly. Quite often I'll find that people know I'm here and I'll be here to see a particular resident, if not a lot of them, but somebody else has happened. We can somehow work out what we can do to move forward, making sure everybody's been seen. We provide the oral health assessment, which you should all be familiar with. It's initially conducted prior to or on admission of an aged care facility, and it should be repeated annually, if not more frequently, if warranted by the resident's health conditions. So depending on the provider, this can be provided to the resident actually in their room without them having to go anywhere, or sometimes they put a dedicated room, sometimes it's the hairdressing salon, some places have their own dental room, which is really special as well. Depending on what the resident needs and depending on the level of scope is where that will be done. We then can develop an oral care plan for the oral health assessment after consultation with you guys at the facility, the staff, the family, and it can be updated as necessary. The plan can include routine dental hygienes and cleans, special assistance, so different aids that might be suggested, things just to help. It could be an electric toothbrush, or it could just be a different type of toothpaste or a different type of handle, something like that. Different equipment, different consumables, and then the recall, how often we feel that resident should be seen to make sure that their health is at optimum level. Next slide, please. Thank you. So after the oral health assessment's been provided, if it's necessary, what we'll do is the oral health treatment plan. So the dental provider will detail the type of treatment that we suggest is necessary, or preventative things we can do to help keep everything stable. This can include things such as cleaning their dentures. We can remove a lot of that bacteria for them. If it's something more necessary, then we can look at getting a different a denture technician in on site to do those kind of things as well. We'll clean the teeth. We'll do a deep clean and scale. Fluoride treatments, preventative treatments that can stop sensitivity, that can stop the progression of decay, trying to keep everything stable, as minimal intervention as we can with providing the best care possible. Sometimes they can take x-rays, and some dental restorations can be provided on the day, depending on the provider. An oral health provider will make arrangements with the aged care facility and the residents or their legal guardian to schedule the appropriate treatment. So either on site, or we can make an appointment at a base clinic. So some facilities may have a dentist that comes on site. There'll be treatment that's required. They might take them off site. If it can be provided, it can be provided in the room, wherever's necessary, but they're the kind of things that the oral health provider will be able to navigate for you. They'll be the middleman to direct you where it needs to go, and they'll do all that groundwork for you. The oral health provider will also follow up on those referrals and any intervention that's out of our scope. So same things, if we can notice they're swallowing things, we'll just check in with the speech path, or we'll look at getting everybody else involved that needs to be involved, regardless of if it's dental specifically related or it's their mouth as a whole. Next slide, thank you. Lovely. So just following on from that, so oral health providers, we can provide you staff continuing education programs. So whether or not that's, in a group setting, like we were talking about before, we can do things in lunch breaks, we can do things out hours. So things to help do that continued professional development. All to do with, of course, aged care and dentistry, and how we can, one, going through the things that Carol's been through for you to educate you on the how and the why, and then you can also look at how little tricks of the trade, how we can help you get in there. Sometimes there's a resident that's not particularly interested in having their teeth cleaned, but there's a few little tricks that sometimes we can help you with, or particular products that might be a good option that you can suggest to family members. So the purpose of those activities is to update staff on oral health knowledge, because there's changes all the time, to discuss, resolve operational changes and maintain the awareness of the oral health. Continued professional activities may include, but aren't limited to, face-to-face or virtual education sessions or interactive meetings, electronic hard copy newsletters, podcasts, some people are savvy like that, recorded videos and social media website type things. Thank you. So I am now going to hand over to Bill, who's going to run through some clinical governance.
Thanks, Gemma. I find it really valuable to consider the number of APRA registered practitioners that provide services to residential aged care homes to support the residents on their oral health care needs. So thank you for sharing. Now, Bill, our final speaker for the day, has extensive experience in a range of organisations, both public and private sectors. He's a pharmacist by trade with qualifications in health admin and business management. Bill has held many executive, academic and regulatory roles in the health sector, with previous appointments including clinical director roles in both public and private hospitals, general manager and CEO roles at a range of professional associations. Bill is currently the CEO of Dental Hygienists Association Australia, and I will pass on to him to discuss clinical governance. Thanks, Bill.
Thanks very much, Tara, and thanks for coming to today's session. And as we have actually heard, the oral health practitioners can do a lot and to support the aged care facilities. And one of the areas that we haven't covered is actually clinical governance, which is quite important now with the new standard for in aged care quality standard. And our profession, the oral health practitioner can actually support the facility by providing ongoing monitoring of oral health activities and also the documentation of all the achievements that you guys have achieved, and assist in quality improvement process on behalf of the aged care facilities. For example, we can conduct audits, we can actually provide reports, and we can evaluate the outcomes and also the service actually input to in oral health for the facility. Oral health practitioner can also attend any relevant clinical governance meetings and participate in any team-based activities in CQI. So this is part of the very important role of a practitioner over and above the daily work that they can do, because they can collect a lot of information, data, document a lot of outcomes and process for you in the area of oral health. Next slide, please. So the benefit for having a regular attendance of an oral health practitioner to your facility are quite extensive. Obviously, you can have access to expert oral health advice and services. We know that you have a lot of medical advice from doctors, nurses, and to some extent dentists. But oral health practitioners like dental hygienists and oral health therapists, they are really specialized in the prevention and the early intervention part of oral health, and their expert advice will be invaluable for you and the residents and also their family members. And we actually can do a lot of documentation on oral health for you, so that each there. One particular area that I like to mention is the oral health assessment, particularly on admission to your facility, because there are quite often the discussion between the family of residents and the staff in terms of the quality of oral health, deterioration of oral health, and that sort of stuff. And if you have someone like a dental hygienist or health therapist who actually can provide that expert assessment and document that for you on a mission, and then at the very least on the annual basis. That will become a very important documentation for your facility, and that will actually prevent a lot of unnecessary the argument further down the track. And obviously, our staff, our members can come in and provide that assessment and provide oral health care plan for your staff and for the family members of the residents. And this is likely to save you a lot of time in terms of because when we do that, we always consult with the staff and make sure that what we propose can fit into your daily routine rather than have to actually do things specially. And then by providing good oral health, as Carol had mentioned before, it would save you a lot of potential costs in medical costs and all the other additional sort of burden to your staff, the individual, the resident, and their family members. Now, one of the things that we believe that the challenges for the oral health for residential facility, aged care facility, is the time and the hassle of getting the residents out of the facility to attend a dental clinic for whatever needs. Our members can actually help you to organize that, to liaise with the dental clinic if required. But in most cases, the majority of services can be provided by our members on site. So save you a lot of time and both for yourself and also the family members. And last but not least, with the proper documentation, with the proper assessment and monitoring, you would meet a lot of compliance requirements on oral health obligations, clinical governance, and also CPD. Next slide, please. So how are we going to do this? But there are different ways of getting an oral health practitioner to actually provide service on site for residential aged care facilities. And there are different ways, and it all depends on how you want to structure the arrangement. Obviously, you can actually have a part-time oral health practitioner on staff. In most cases, it depends on the number of residents that you have and the type of service you want. But I believe proper oral health assessments might take 1 to 2 hours to conduct, and then depends on the assessment, the type of work that's required. For example, you might want the practitioner to provide basic scale and clean service. Or you might want to repeat the assessment every 12 months or 6 months. So it all depends on the extent of the service and also the number of residents that you require. But in most cases, a part-time staff regularly visiting your facility will be serviced, and that wouldn't cost too much at all if you want to put on part-time staff. However, if you don't want to put on a part-time staff for whatever reason, you could actually make an arrangement, contract arrangement with a oral health practitioner, and they can come in on a regular basis and then provide the service as a subcontractor. So it's not an employment arrangement; it is a contract arrangement, and you'll be billed directly for the time and service with that service provider, and obviously you need to organize a service agreement. Or alternatively, you still can have the regular visit by the oral health practitioner, but it can be done directly between the resident's family and the practitioner, and your facility can provide that opportunity for a practitioner to come in, but basically they can directly liaise with the resident on the private basis, and the billing and that sort of stuff can be organized directly between the family, the residents, and the practitioner. And finally, there's an opportunity for you to actually contact the local dental clinics, dentists, dental surgeries, and organize a service agreement with them. But that is probably the least preferred way, because number one, there's very few fixed clinics will be happy to do that, and or they might not have people who will be willing to drop in to provide on-site service. And then if you have to make appointments to send your residents over to the clinic, then you defeat the purpose of having oral health services on site anyway. So these are different ways of providing the services. And if you want to actually explore further, next slide, please. You can contact me through the Dental Hygienists Association of Australia, and we can actually offer support to link you up with your local service provider, and we can actually help facilitate a service agreement or employment for you. And I'm happy to actually answer any further questions that you have. And I hope that you will be able to contact me in the future, so that we can actually help you to improve the oral health and then the general health of the residents. And hopefully you'll find the profession will be an asset for your facility. Thank you.
Thank you so much, Bill, for sharing the ways that Dental Hygienists Association Australia can support our residential aged care facilities. We are getting close to time. There's not too many questions that have come through the Q&A box at this time. However, if you do go away at the end of this webinar and have any questions, you can email. You have Bill's email address, ceo@dhaa.info, and also our engagement.qld@health.gov.au email address that you can send any questions through to. We would also appreciate if you could take some time to complete a short survey just to improve our webinars and to ensure that we are delivering information and resources that are relevant to your needs as aged care providers. We have a link in the chat and also a QR code that you can scan. The survey should take no more than a few minutes, and it would be really valuable for us to make sure that we improve our services for the future. So this does bring us to the end of today's webinar. As mentioned earlier, there is a recording of this webinar, which we will send via email. I will also attach the slides from today's presentations for you to review as well, and you can share the link and the slides with other staff members who might not have been able to attend the webinar today. So again, thank you for your attendance, and we appreciate the feedback that you have for us, and we will see you soon. Thank you.
Thank you.
Thanks,
Bye.
everyone. Thank you.